So, Dr. Scholz, today we're talking about men who have failed first-generation hormone therapy like Lupron and things of that nature. Now, men have been on Lupron in this situation usually for quite some time, and they kind of have this feeling like, okay, we're checking the PSA level and maybe they're seeing a slow rise. Now, I know in PCRI, and thanks to your training, we've always talked about the difference of how a man has to think when he's on Lupron versus when his PSA is rising, and it's a different game. So really, my question is, does a man go all in and treat this very aggressively? Are there certain steps and sequences that he should take? What are your thoughts?
So we're talking about androgen independence. We're talking about hate the word castrate-resistant. In our stages of blue system, we talk about it as low royal, and it's a major watershed event because Lupron, as you pointed out, has been working for many years. And if our effective treatment stops working, then the situation is defined by finding a solution. But there's a lot of solutions now, and it's hard to know which one is best. The rate of PSA rise gives you a clue as to how serious it is. In the studies that were done for the approval of Zytiga and Xtandi and these medicines, they looked at the PSA doubling time. And if it was going up really quickly, i.e. doubling in less than 10 months, then that was justification for going on these medicines. One of the things I find intriguing about what we should be doing at this point, because we know we're entering into a time of more serious prostate cancer, castrate-resistant prostate cancer, should we be using our medicines one at a time, use them up one at a time, and stretch out the time that we can use them? Or is it better for patients to go on 2 or 3 medicines right from the get-go to try and really mop up the cancer and buy a long remission? If you look at those 2 different approaches, usually the latter approach, combination approach, has translated into better long-term outcomes. But it's a little more confusing in prostate cancer because long-term outcomes in prostate cancer could mean 10 to 20 years. So you could argue that sometimes giving combinations is an overkill. So the doubling time probably guides that decision about whether to go with a combination or just to give one medicine. And of course, the age of the patient. If we can keep someone alive for 5-10 years and they're already 85 years old, then a simpler approach is very reasonable. Perhaps just something like Xtandi or Zytiga as a single agent. But if someone's younger and the PSA is going up quickly, I think that a combination approach is a much more attractive way to go. And that, for me, would mean some sort of immune therapy and also in combination with a second-generation hormone medicine like Xtandi or Zytiga. And the problem is that if men's PSAs are very low, immune therapy with, say, Provenge is not necessarily covered by insurance unless they can find a metastatic site. And fortunately, we've got better scans, PSMA PET scans, that can find spots of cancer even at very low PSA levels. And if that's achievable, then a sequence of giving some Provenge, maybe adding some experimental Keytruda, zapping the spot with some radiation like SBRT, and then going immediately on a second-generation hormone therapy like Zytiga or Xtandi will put almost 100% of men into remissions, and those remissions will run, in my experience, for many years. So I think one of the questions is, do you want to use sort of a full-court press, or do you want to just start a pill and ride that horse and then think about other treatments later? If the pill starts running out of gas, then it's an even more serious situation. If the Xtandi or Zytiga stops working after a period of time, then you're on to chemotherapy, and there are fewer and fewer options. So when in doubt, I tend to use a combination approach.
So you mentioned with Provenge, in order to be able to take that, you need to have a metastatic lesion. When they say metastatic, is that bone met or is that lymph nodes?
Any metastatic lesion, anything outside the prostate. So if it's a lymph node, bone, spot on the lung, liver, doesn't really matter, just so there's something outside the prostate.
In combination therapy, that's a lot of different drugs or treatments all at once. What type of side effects have you seen with these patients?
Well, Provenge, the side effects are minimal. The side effects of Zytiga and Xtandi are very similar to what people have been going through with Lupron already. So the quality of life is good. If someone ventures down the pathway of adding experimental Keytruda to the Provenge, then the side effects can be more notable. Men can develop diarrhea, shortness of breath, rashes, and a variety of things that an overactive immune system can do.
I know Keytruda is approved by the FDA in a very small percentage of men. I think it was 4 or 5% of men who have a specific genetic mutation. Can you explain what that is?
So MSI mutation in any kind of cancer, lung, bone, prostate, it responds very frequently to Keytruda, and the results are rather amazing. It's a rare mutation. I haven't personally seen it, although we test for it in all of our patients now. And that particular setting, called MSI, that the insurance companies will cover payment for Keytruda. And Keytruda should definitely be given because the response rates are so favorable.
What tests do you do on men at your practice in order for them to test for this?
There's a couple blood tests that we commonly use. One's called Garden 360, and the other is called Foundation 1.
So that leads me back to an overall question when it comes to men who are becoming castrate-resistant. What genetic testing should a man look at early on when his Lupron stops working in order to help enhance treatment decisions?
Yeah, so there's another recently approved drug, olaparib, which only is FDA approved for treating men that have the BRCA mutation. And that is also detected with the same blood test that we already mentioned. And men that have that mutation have high response rates with olaparib and rucaparib and should get good results with those medicines. But you have to establish that that particular mutation is present. It's present in about 15 to 20% of men with advanced disease.
Thank you for watching. If you would like more information about anything that we spoke about today, you can visit our website, pcri.org. Also, please subscribe to our YouTube channel. We come out with new prostate cancer videos every week.